Good afternoon, everyone. I want to thank you for being here. Welcome to the House Committee on Veterans Affairs' first oversight hearing for the 119th Congress. Now, before we start, I wanted to recognize and thank my colleagues and friend, Chairwoman Miller Meeks, for her leadership. Chairwoman Miller Meeks originally proposed this hearing topic to be held in a subcommittee, but ultimately I decided this is important. This is an important enough issue to discuss that requires full committee attention. And as chairman, I am deeply committed to our shared mission of improving the delivery of care and services to our nation's veterans. And I look forward to working alongside my colleagues on both sides of the aisle to fulfill this mission. Last Congress, this committee did meaningful work towards the mission by passing the Dole Act. The committee also performed critical oversight of the Biden administration VA to find where the shortfalls were. Today, we turn our focus on VA's community care program, which, as we know, is today was enacted in the VA Mission Act. The VA Mission Act passed in 2018 with overwhelming bipartisan support. It was a promise to veterans, a promise to ensure they would never again face delays in access to the health care they have earned. It was a solution born from necessity and on the shoulders of what was the Choice Act. It was designed to eliminate barriers to care and expand access for veterans nationwide. It is not a solution to it is not a solution to privatize VA health care. Let me say it again, not to privatize health care, the VA health care. Anyone who suggests otherwise should step outside the Beltway and talk to the veterans who live 3 hours from a VA medical center. Community care is that veteran's lifeline. Healthcare decisions are deeply personal, and they should be made by veterans themselves. They know where and when, and they need care to fix their needs. However, under the Biden-Harris administration, the program has been hijacked. The Biden-Harris administration has prioritized bureaucratic limitations and control of community care over veterans' needs. Scheduling practices have been manipulated to distort wait times. Appointments have been canceled or rescheduled without veterans' consent. Internal VA guidance has actively discouraged veterans from seeking care outside the VA system. That's dead wrong. And like everywhere else, like every other law that is enacted, it is not optional, and it's not a suggestion, it's the law. When VA inserts itself as the sole decision maker and plays politics with veterans' health, people get hurt. These actions have real-life consequences, and we're going to hear some of those consequences today from actual veterans, not bureaucrats. Make no mistake, community care is VA care. It is not a substitute, but an essential extension of VA's mission to serve veterans where and when they need it, without delay. With the Trump administration in place, we have the opportunity to ensure VA adheres to the Mission Act and returns healthcare decisions to the hands of the only authority that matters, the veteran. Today, we will hear from witnesses who have experienced these barriers firsthand. Their stories will remind us that the decisions made here in Washington have a far-reaching impact on the lives of veterans and their families. To our witnesses, first off, thank you for the courage and sharing your experiences. Your experiences matter, and we are here to listen. Now with that, I now recognize Ranking Member Takano for his opening comments.
Well, thank you, Mr. Chairman. Today, we will hear perspectives from several veterans who have faced barriers in trying to access timely and high-quality health care from the Department of Veterans Affairs. I want to say to our witnesses that I am truly anguished by the unacceptable delays to you and your veteran loved ones. I am anguished by what they have faced and what you have faced in getting the care that you and they need. Your experiences are deeply troubling, and I have many questions about how things went wrong. Unfortunately, I'm afraid that today's hearing will not help the committee get sufficient answers to those questions, and it will not enable us to hold those responsible accountable. That is because the majority has opted not to invite any witnesses from VA or the 2 third-party administrators of its community care program. They also opted not to include witnesses from agencies like VA's Office of Inspector General or the U.S. Government Accountability Office, who could provide us with objective, fact-based information about how and why veterans experience delays in accessing health care. This hearing was hastily organized just hours after our committee organizing meeting last Thursday. We have 6 members who are new to this committee, to Congress, 3 of whom are physicians and understand better than anyone the importance of proper care coordination and the risks of delayed care. Mr. Chairman, today's VA Community Care Oversight hearing is the first that you have convened since becoming chairman more than 2 years ago. More than 40% of veterans' care is now being delivered in the community, and VA is on track to spend more than $42 billion on private sector care this fiscal year. When I was chair of this committee from 2019 to 2022, the full committee and the health subcommittee collectively convened 6 oversight hearings that examined the timeliness of veterans' access to health care and payments to community providers, as well as VA's initial implementation of the Mission Act. I'm explaining all this because what I'm about to say may shock members, veterans, and other stakeholders watching today. Last Thursday, we were informed that this one-panel hearing will be the only full committee oversight hearing on community care before we advance major legislation on the subject, and that we had to content ourselves with 2 closed-door, committee staff-only meetings with stakeholders. However, since the committee had not formally organized at the time these meetings occurred, no members or their staff were present. Moreover, because these meetings were held behind closed doors, there is no public record of what was discussed. The minority is only permitted to invite 1 witness to a hearing, and given that the current transition in presidential administration presents challenges with inviting government officials to testify, so I asked the majority to invite Optum Serve Federal Health Services, one of the third-party administrators for VA's community care program. Optum is a subsidiary of United Health Group and has contracted with VA since 2019 to establish networks of community providers and process payments to those providers. United Healthcare also holds a contract with VA to conduct medical disability examinations, the exams veterans receive when they are applying for VA disability benefits. Today, United Healthcare's VA contracts are worth more than $72 billion. That's billion, with a B. Worse, that money is not all spent on providing care to veterans. A considerable amount is going to administrative overhead. Imagine how many new hospitals and clinics VA could build and how many clinical staff that VA could hire with that amount of money. However, United Healthcare declined the invitation to testify, citing the lack of sufficient time to prepare for the hearing. Now, I don't know about you, but I don't have much sympathy for a company that is receiving tens of billions of taxpayer dollars, complaining that they need more advance notice to appear at a hearing. The chairman's staff, however, apparently do sympathize because they accepted United Healthcare's excuse. Now that brings me to Dr. Saindon, who is appearing today as the minority's witness. She serves on the board of directors of the Nurses Organization of Veterans Affairs, otherwise known as NOVA. NOVA is a nonprofit professional association whose mission is to educate, communicate, and advocate for VA nurses. NOVA is not a part of VA, nor is it a union. NOVA managed to do what United Healthcare could not, arrange to get Dr. Saindon to DC to testify with less than 2 business days' notice. So I want to thank Dr. Saindon for being here today. Now, I know we won't get answers to all our questions in this single hearing. Veteran stories are an important part of oversight, and I thank our witnesses again for their bravery and candor in participating in today's hearing. However, oversight is not complete without accountability, and there are no accountable individuals here today. No accountable individuals are appearing before us today. And I want to be clear that I recognize the importance of community care. However, I also do believe any further expansion of community care must be met with similar investments in VA direct care. The two systems should be complementary, in balance with one another, to ensure veterans can access the best, most timely, culturally competent care. But that is what is not happening right now. Community care has expanded at the expense of VA direct care. And if we continue down this path, VA will crumble. And this is where I draw the hard line. Our veterans cannot afford for us to dismantle VA direct care in favor of shifting more care to the community, nor by all accounts do they want us to. Rushing to pass this legislation without sufficient oversight and diligent efforts to uncover the root cause of problems is a recipe for disaster. For example, in 2014, after news of quote-unquote secret VA waiting lists broke, Congress acted quickly to create the Veterans Choice Program, a temporary program that allowed veterans to receive community care when they faced long wait times or lengthy travel distances. We went from bill to law in the course of 3 months. As we found out over nearly 4 years, over the 4 years that followed, the choice program actually resulted in longer wait times, confusion about payments, and administrative headaches for veterans and staff at VA. Then in 2018, Congress passed the Mission Act, further expanding community care eligibility. Yet here we are today with veterans and VA staff facing many of those same issues with access, care coordination, and transparency. All the while, VA has been rolling out more policies and contract modifications, altering the administration of the community care program. How can we address the effect of these administrative changes if we are not conducting proper oversight? This committee also needs to conduct more oversight of the quality of care veterans are receiving in the community. As we will hear from many of the witnesses today, simply getting a referral to the community is only the first step. We must also ensure that these referrals are actually leading to veterans receiving high-quality care. Furthermore, we need to ensure that we are being good stewards of taxpayer dollars, as our majority so often reminds us. Care provided in the community often comes at a higher price tag and can be less efficient and less effective than care that VA can provide directly. And we must also consider the long-term future of VA, which serves not only our veterans, but all Americans, through its role in providing world-class and groundbreaking medical research, its fourth mission emergency preparedness mandate, as well as providing residency and fellowship training for more than 70% of all U.S. healthcare providers at some point in their careers. As a committee, we must candidly assess the long-term and far-reaching consequences of undermining the VA direct care system in favor of prioritizing private healthcare profits. And with that, I yield back.
And thank the ranking member for his testimony. Let me tell you that this is the first of many hearings focused on community care. We are in our very first hearing. That gives us a golden opportunity for a lot of them. This hearing is solely focused on hearing the veterans' stories so that we can work on this. But let me explain this to you. The VA, and I've said it so many times, the VA was created not for the VA, not for the bureaucracy, but providing for the veterans. And in this hearing, we decided we want to hear from the veterans. And as my position as chair, let me say this again. It is not the majority's position to privatize the VA, but to make sure the VA delivers to our veterans at the level that they need to have their care given to them when and where they need it, with less bureaucracy and given in a way so that incident after incident after incident does not occur where someone falls through the crack for whatever reason, whether it's in the community or at the VA. So with that, we will turn to our witnesses. Testifying to us before us today is Paul McKenna, say that correctly for me there, Sergeant Major.
Good afternoon, Chairman Bose.
I'm just introducing. I was just trying to pronounce it correctly.
Paul McKenna.
McKenna, thank you. Now, he's a sergeant major of the Marines, traveled from Representative Murphy's district in North Carolina. We also have William Dooley, a 20-year Army veteran traveling away from Congressman Self's district in Texas, Miss Lori Willis Locklear, a former VA employee and mother of a Navy veteran, Logan Willis, traveling from Representative Harris's district in North Carolina, Miss Brittany Dymond, just Dymond, there you go. I always wonder why they put that out whenever it's just pretty well spelled that way. Associated Director of Veterans for Veterans Foreign War, and Dr. Kelley Saindon, Secretary Treasurer of the Nurses Organization of Veterans Affairs. Will the witnesses please stand and raise their right hand? Do you solemnly swear that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Thank you, and let the record reflect, you may sit down. Thank you, and let the record reflect that the witnesses answered in the affirmative. I now recognize Sergeant Major McKenna for the 5 minutes to deliver your testimony. Sergeant Major.
Good afternoon, Chairman Bose, and for the record, I'm retired. Chairman Bose, Ranking Member Takano, and members of the House Committee on Veterans Affairs, thank you for inviting me to testify for the record of today's hearing on veterans' experiences using the Department of Veteran Affairs Community Care Network. I'm here today as a voice for countless veterans in Eastern North Carolina who continue to struggle to effectively and efficiently utilize the critical part of the VA's healthcare system. As the committee is aware, the VA Mission Act became law in 2018 and was intended to improve access to health care for veterans. My aim today is to illustrate the gaps and seams within the pillars of this legislation that are present in Eastern North Carolina, with specific attention on access to care, the community care network, and the education and training of the VA workforce that coordinates access to care in the community. My hope is that my testimony will offer the committee some insight to the real challenges that veterans face when using the community care network in Eastern North Carolina. Additionally, and what may sound anecdotal, is to share with you my experiences with using the services of the VA Community Care Network in 2 different geographical locations, and the experiences of many veterans I have talked to who must utilize community-based services. My name is Paul McKenna. I retired in 2021 after 36 years of active duty service in the United States Marine Corps. I've learned many lessons, life lessons, from my nearly 4 decades of service as a U.S. Marine. And at the very top of that list is that no American can afford to be disinterested in any part of their government, county, city, state, or nation. One of the great lessons the Marine Corps taught me was to never take for granted of being in the presence of other Marines and their greatness. For 36 years, I walked amongst giants. I will forever cherish those relationships, especially the relationships of those American heroes that never came home. I truly hope that my actions and words today bring honor to their memory and their sacrifice.
Thank you, Mr. McKenna. Mr. Dooley, you're recognized for 5 minutes.
Thank you, Chairman Bose, Ranking Member Takano, for inviting me to testify on my frustrating experience with VA Community Care, specifically Dallas, Texas, Veterans Affairs Medical Center. I sit here today as a veteran, father, husband, and cancer patient. I apologize for my appearance and any speech deficiencies that I may have while reading my statement. I finished my final chemo treatment a week ago, and I'm still having several side effects. I'll start from the beginning of my cancer journey. In September of 2023, I voiced my concerns for symptoms while a regular scheduled doctor's appointment. In November of 2023, I voiced my concerns again by scheduling a doctor's appointment for these same symptoms in Bonham, Texas. I completed a sample submission for the doctor, and he ordered a colonoscopy. I was told by the scheduling that they were backlogged and community care would be my best route to get care. I was referred to community care in December of 2023. I was matched with a community care provider, Jenny Sang at the time. My community care provider informed me that May 20th 2024 was her first available for the colonoscopy. I was scheduled for a colonoscopy 9 months after I voiced my concerns with my primary physician and 5 months after being referred to community care program. On May 20th, I received the colonoscopy and woke up with the dreaded words, "You have cancer and need surgery immediately." Multiple phone calls from myself and my wife to the Veterans Affairs resulted in almost no movement forward. I was told it'd be September before I would receive the cancer testing required prior to surgery. I was told I had cancer and the best they could do is get me tested in 4 months. This was not acceptable. Community care was my best option to survive. We scheduled my first appointment with UT Southwestern Oncology with the assistance from UT Southwestern. We were able to get scheduling for all required tests set up the following week, not 4 months. Community care was no assistance, and we used our personal insurance for the doctor visit. We eventually received a referral and approval from the required testing and received approval for cancer treatment at UT Southwestern. This was only after reaching out for assistance from Representative Self's office. Unfortunately, after the testing was conducted, it was revealed that I did not have stage 1 cancer, and due to too much time passing for the original colonoscopy, I was currently stage 3 cancer, and my lymph node system had been compromised. At this point, I was informed by the oncologist that surgery first was not an option, and that a very aggressive chemotherapy and radiation treatment was my best option for survivability. The treatment would consist of 8 rounds and 2 types of chemotherapy and 5 rounds of concentrated radiation. Followed by successful treatment, I would be evaluated to determine the level of surgery required. I was informed in August, after receiving several bills, that the treatment I received was not covered. This was due to the referral for cancer treatment not including chemotherapy or radiation. I was informed of this unit because the billing was rejected only. Once again, we reached out to Representative Self's office for assistance. I do not believe we would receive this approval without the assistance from his office. 3 major problems I encountered during this process. First, the community care program does not communicate directly with the provider other than the original scheduling. This leads to confusion for the veteran, adds possibility of poor case management and the treatment for the veteran. In my case, the community care worker could have assisted by contacting me and letting me know if 5 months wait was the only option or if other care providers had availability sooner. Second, the approval of one of the procedures but not the others is known to be required together. Cancer treatments for us non-doctors usually comes in 3 forms, and in most times, all 3 are used: surgery, chemotherapy, and radiation. Why is a standard procedure to approve surgery but not the other 2? It is very confusing to need 3 separate referrals for the same treatment plan. It adds to the confusion for billing and for referral management, especially when all 3 have different expiration dates. At no point did my caseworker have direct contact with the provider to discuss the issue and how to resolve it. Any attempt to call my caseworker and facilitate a 3-way call resulted in leaving a message and waiting for a call back. This was due to my caseworker being a remote employee and not being provided a direct phone number to her. Third is the lack of professionalism and compassion from the VA employees. From the beginning of this journey, we have been sighed at, told to wait, told to be treated with disdain by the employees we encountered. I was treated like I was asking for charity and not treated as a disabled veteran that was trying to receive life-saving treatment. Case management displays some of the worst incompetence I've seen in decades. On one of the occasions, the response that I received from the VA was intertwined with mistruths and blatant lies about timeline and what happened. This was very concerning. At no point has anyone taken ownership or conducted an assessment of what could have done differently. The response was deny, and counter-accuse. Accountability for poor performance and low proficiency is not a strong point of Veterans Affairs. All these problems were shown last Friday after my submission of my written testimony. On Friday, I received a phone call from the Veterans Affairs. It was my primary health care provider. The message was primary health care provider asking if I had been scheduled for treatment for the 2 referrals for chemotherapy and radiation. I had just finished 8 rounds of chemotherapy and 5 rounds of radiation. They'd been scheduled over a 5-month period and paid for by the VA. But my primary care provider had no idea if I'd even started chemo or radiation, and still doesn't today. This shows the direct breakdown in any communication between community care, my primary doctor, and the community care provider. A lot of these questions and concerns could easily be fixed if someone cared enough to do their job as a case manager. The upper-level bureaucracy and lack of accountability for poor performance in the Veterans Affairs has become just as much of a cancer as what courses through my body today. I can work on fixing my personal health, but I'm asking you to work on fixing the Veterans Affairs because it's unhealthy and full of cancer. I appreciate the time and opportunity to share my story. More detailed information with names and dates has been provided in my official written statement. I look forward to any questions you may have at this time.
Thank you, Mr. Dooley. Ms. Willis, Locklear, you are recognized for 5 minutes.
Hello, Chairman Bost and Ranking Member Takano and the House of Representatives, Committee on Veterans Affairs. My name is Lori Willis Locklear. First, I want to thank God for getting us here. Thank you for the opportunity to speak on behalf of my son, Logan F. Willis, who served in the United States Navy from August 2017 until December 2018. Logan was our only child, and his dad, Raymond F. Willis, was an Army veteran. I was a VA employee for 12 years. Logan spent his summers volunteering at the VA. His father passed away in 2015 from lung cancer. It was very difficult on us both. He graduated from high school in 2014 and the University of North Carolina at Pembroke in 2016. Logan wanted to further his education, so he enlisted. His first duty station was Sasebo, Japan, aboard the USS Wasp, and it was during that time that Logan's mental health began to decline, and he attempted suicide multiple times on the ship and later in San Diego. Logan received an honorable discharge on December 31st, 2018, and returned home. I noticed many changes in Logan's demeanor and behavior. He was not the same person. As a VA employee, I directed Logan to seek help from the VA, but was told, "We can't help you." At this point, he developed a distrust for the VA system. Logan was so distraught with the lack of support he had received at the VA one day, I came home and Logan had packed up all his belongings and left. Later, he stated he could no longer live in a place where he felt unsupported. The saddest part for me as a mother is that Logan saw me as the VA. Unfortunately, Logan could not see that I was working as hard as possible to help him. I was a mother of a veteran and an employee, but the mother always came first. In the fall of 2019, he entered the master's program at Wake Forest University. He was still struggling with depression and anxiety, but he was focused on earning his degree. He was receiving counseling that he paid for himself and his medications. As we all know, 2020 was the year of COVID and everything shut down. His classes were all online. There were times when Logan would not leave his home for weeks. I checked on Logan, visited, and encouraged him constantly. He became more isolated. As a VA employee, I saw a veteran who was in trouble and needed help. With no trust in the system, he would rather suffer than seek help. Sadly, we see this so much with too many of our veterans who have served their country. Logan graduated on May 14, 2022 with a master's degree in divinity. After graduation, he was unable to find a job and had to move back home. As his mother, I encouraged him to seek the services he was eligible for, but once again, he was skeptical, but decided to reach out to the local Veteran Service Center for help in June. At the meeting with the Veteran Service Officer, he seemed encouraged. As a pharmacy technician, I feared that Logan was over-medicated. On September 1st, 2022, I requested a session for Logan to speak with our pharmacist so he could ask questions about his meds and their side effects. Afterwards, I sent Logan to check in and request a mental health provider. He said later that he had been given an appointment. However, I learned after Logan's death that his appointment was not until 5 months later, for February 2023. Logan's mental health issues needed immediate help and again was not met. He was met with a broken system. The Community Care Act, to my knowledge, was not offered. Protocol at that time was if a veteran requested a mental health provider, they were to be seen or sent to community care within 20 days. Logan died 63 days later. He was never contacted. November came, and there was still no action in regards to the services Logan had requested, to my knowledge. Again, he was disappointed in the VA, and as a result, his anxiety and depression increased. As his mother, I was still working to find help for my son. On November 4th, 2022, my worst nightmare occurred. Logan was found in the bathtub at my home by his stepfather with a plastic bag over his head and a helium tank with a hose beside him. I returned 2 weeks after Logan's burial. I was very unstable and not well, but I knew I had to go back to work and report a suicide. After doing so, I waited for weeks, and I was never contacted as an employee or a veteran's family member. It wasn't until February 23rd I contacted the director to make sure she was aware. She stated she did not have knowledge of said death. I continued to work for as long as I could. I missed most of 23 from my job. I was not able to function. I took an early retirement. I had to go home. The next year, I contacted everybody and anybody that honestly would speak to me. And no one wanted to talk to me, and I was treated like a whistleblower. And so today, I feel like a whistleblower. And so that's all I have to say.
First off, thank you for your testimony. Thank you for the three of you. We're going to come back. A vote has been called in the House. The committee will stand, and I hate to do this right in the middle of this, but it is what happens here, okay? This is a very serious subject, and if the members would please go to the floor. We have 2 votes, and then return as quick as possible, but the committee will stand in recess at the subject to call the chair. We expect to reconvene about 10 minutes after the last vote has been called. So thank you. Committee will come to order. I do want to apologize to our witnesses. It is part of what we do around here, but the timing was not well. Anyway, Ms. Dymond, you are recognized for 5 minutes to provide your testimony.
Chairman Bost, Ranking Member Takano, and members of the committee, on behalf of the men and women of the VFW and its auxiliary, thank you for the opportunity to provide our remarks on this critical topic. The VFW believes the VA Community Care Program and its network of providers are a vital component of VA healthcare. However, it doesn't always work as Congress intended. My story is just one example of a negative experience that could have been avoided. For 10 years, I exclusively received DoD and VA-provided mental health care. Not only did DoD not diagnose me with PTSD, the VA did, but VA providers also failed to identify the complexity of my PTSD diagnosis, resulting in treatments that didn't fully help. Despite consistent care, I battled crippling emotional numbness and had come to blame myself for being defective. I also started experiencing passive suicidal ideations. In late fall 2021, I was referred to a civilian therapist through VA Community Care, and she diagnosed me with complex PTSD, the first time I recall a mental health professional using that term. In May 2022, based on my trauma history, symptoms, and her clinical expertise, she recommended a PTSD inpatient program with very specific treatment criteria. However, DC VA staff would not authorize a referral to the program because it was in Utah and its physical location was in Community Care Network 4. We were told to choose a local program instead. Following a service-connected surgery, I revisited the inpatient treatment discussion with my therapist. This time around, however, I had done extensive personal research, which indicated that in addition to a method called EMDR, a relatively rare therapy called IFS was effective in treating complex PTSD. My therapist and I decided to try to get approval for an Arizona program that was also in Community Care Network 4 on the West Coast, but offered both EMDR and IFS. In July 2023, frustrated with the seeming lack of urgency on VA's part, I physically went to the Washington, D.C. VA and spoke with a social worker who promised to advocate for a referral on my behalf. Again, the referral was denied due to its geographic location, but the social worker promised that he would keep trying. Unfortunately, he went on emergency medical leave, and my request for inpatient treatment fell through the cracks for over a month. In September 2024, VA staff tried helping me find East Coast treatment options. However, so much time had passed since my initial request in July, I would have to wait until January 2024 for my next opportunity to enter treatment. I tried finding Utah and Arizona comparable programs, while the VA employees offered in-network options on the East Coast. It felt like trying to find a needle in a haystack, and VA's suggestions generally fell short. Some programs were too long, while others were only part-time. Some had poor reputations, while others did not offer the correct treatments. Or they were primarily focused on mental health conditions I didn't have, like eating or substance use disorders. One facility was for patients who were dangerous to themselves or others, which was inappropriate for me, while another was co-ed and did not understand why I would want to go to a women-only treatment program. After weeks of searching, we found a compromise program in Pennsylvania that met some of my criteria but did not offer the EMDR or IFS treatment modalities that I needed. I agreed to go there, and fortunately, my assigned therapist was able to help me understand my complex PTSD symptoms. And she ensured my follow-on care was with a qualified professional who did provide those needed treatments. I am lucky to have landed with the civilian therapist that I did, and for the resources, family, friends, coworkers, and accommodating employer that I have. Not all veterans can say the same. However, getting the right mental health care should never hinge on luck. I've since learned that suicidal ideations are actually a product of the fight element in one's fight or flight response, essentially giving out. Had I not been knowledgeable and advocated for my treatment needs, and as a result been sent to a treatment program that couldn't truly help me, it could have been my last attempt at getting better. VA must stop its practice of rationing inpatient mental health care based on arbitrary, seemingly thoughtless guidelines. Arbitrary location rules should never be the only factor in determining which veterans have access to life-saving care. Providing veterans with the correct mental health care the first time means saving lives. Chairman Bost and Ranking Member Takano, this concludes my testimony. Again, the VFW thanks you for the opportunity to testify on this critical issue. I'm prepared to take any questions you or members of the committee may have.
Thank you, Ms. Dymond. Dr. Saindon, you're recognized for 5 minutes to provide your testimony.
Chairman Bost, Ranking Member Takano, distinguished members of the committee, on behalf of the members of Nurses Organization of Veteran Affairs, or NOVA, thank you for allowing us an opportunity to present our views on the topic restoring focus, putting veterans first in community care. As a VA nurse, I want to begin by expressing my sincere sorrow hearing the stories from the witnesses at this table. It's important that we learn from these cases to improve care and the veteran experience throughout the VA. NOVA understands and supports community care when access to VA is not readily available, the distance is too far, or the VA does not provide the needed care. We recognize and acknowledge that we cannot serve everyone everywhere. Our priority is to ensure veterans receive the highest level of care within the VA and utilize community care as needed to enhance the healthcare experience. Since the passage of Choice and Mission Acts, community care has rapidly expanded. Community care referrals have risen by approximately 20% annually, and 44% of VHA healthcare funds are spent on community care. While the Mission Acts expanded community care, it was not meant to replace VA's integrated healthcare system. The legislation was meant to provide a balance between non-VA care when necessary while bolstering VA direct care. We're beginning to see shifts in care and staffing that risk diminishing the superior care that VA provides veterans. Provider shortages and budgetary constraints continue to affect VA care and community care. The constriction and closure of community healthcare systems have raised concerns about how and when veterans can be referred to the community. The community healthcare systems are saturated and cannot absorb the continued increased demand for veteran care in the community. Despite innovation and improvement focused on efficiency for community care coordination, the policy-driven steps remain laborious. Inconsistency in scheduling and authorizations across the system create confusion for veterans and for our community partners. A public-facing site that provides detailed information about community wait times, quality metrics, provider credentials, and provider training is imperative for veterans to make informed decisions about their health care. VA clinicians are more likely to have experience and specialized training in recognizing, diagnosing, and treating conditions often encountered by veterans. They are uniquely trained not only on military culture, but on veteran-specific exposures. The standards for our community providers should be no different. The oversight of care in the community is inadequate at best. We recommend Congress implement strong action and enforcement of mechanisms to increase quality and oversight of community care. Failure to meet quality expectations should result in removal from the network. It is vital that VA facilities have more control over services provided in the community. Records must be received promptly so the VA can direct further care, including any necessary diagnostic testing. Without proper coordination between VA and community providers regarding the timely return of medical records, veterans may not receive the necessary information to make informed healthcare decisions. For example, this vulnerability is especially important with lung cancer screening, lung nodule follow-up, mammograms, and colonoscopies. Stories from our membership include VA community care staff requesting records 3 or 4 times to the community provider with no response. This leaves the veteran at risk for serious and, in some cases, life-threatening poor outcomes. We recommend the Community Care Network have prescriptive guidelines for record sharing. Current practice leaves much risk for healthcare decision delays. We encourage Congress to implement business rules that permit payment upon receipt of medical records. Studies have consistently shown that VA care equals or exceeds the quality care provided by the private sector. Recent star rating reviews demonstrate that VA hospitals score higher than non-VA facilities in both patient satisfaction and quality of care. My hospital, White River Junction, Vermont, received a 5-star overall hospital and 5-star quality rating in September 2024. It was the only facility in Vermont and New Hampshire to earn the top rating. A 2024 VFW survey showed overwhelming support for VA to remain the primary deliverer of care for veterans, with most of them saying they prefer using VA medical facilities for their healthcare needs. The VA must remain the primary provider and coordinator of veterans' healthcare, using community care as a supplement when VA services are unavailable. Authorizations and referrals should follow access and eligibility standards. Requirement for both VA and community care should include consistent quality and training standards. Listening to veterans' stories helps us understand their needs. NOVA is committed to working with Congress, community partners, and VA leaders to ensure veterans receive timely access to the highest level of care. Thank you again for this invitation to testify. I'm happy to answer any questions the committee may have.
Thank you. And before we get started, I'd like to thank Representative Harris, who represents Ms. Locklear in Congress. He will be joining us later on, but we need to make sure that in accordance with Committee Rule Number 5E, unanimous consent, that Representative Harris from North Carolina be permitted to participate in today's committee hearing. Without objection, so ordered. I recognize myself for 5 minutes. Questions. Ms. Locklear, you shared how your son struggled to access mental health care. If VA had told Logan about his community care eligibility early on, do you think it would have made a difference?
Logan died, and I got some bank statements, his last bank statements. I have bank statements that shows he spent $800 and some in like 2 months for his mental health care. He called me one day at work, frantic, saying, "Mom, I'm out of my medications. What am I going to do? What am I going to do?" I said, "Logan," I directed him to go to his local pharmacy. I said, "No pharmacist is going to withhold your mental health meds from you till you can get a new prescription." He did so. He came home. He had bought $288 worth of medication that day. And I looked at the receipt, and I was like, "Logan." He said, "Mama, that's what they said it was. So I just paid it." And I was like, that is one of the reasons why I brought him into our facility, set him down with our pharmacist, because they knew the meds he was on. And they said, "Lori, these drugs he's on are dangerous." And so that's the reason after we had that discussion, I said, check in. I told him, I said, "If I could get you into my facility, I can help manage and take care of your mental health needs and his medications." $288 that he paid for out of his pocket. My son was going into a hole trying to take care of his mental health.
And he didn't know that it was available to him.
He knew it was available, but I mean, he had no faith in the VA. And then when I finally talked him into it, there was error after error after error that was done in paperwork. He checked in. He got a 5-month appointment mental health. If he had came home and told me that they had given him a 5-month appointment, I'd have said, come right back to the VA tomorrow. I'm going to go down there with you. I would have questioned him. Why are you giving a young man, if you looked at his record, he had tried to attempt suicide multiple times in the military. I don't understand why he didn't have an appointment when they allowed him to an honorable discharge in December. Why wasn't he given a mental health appointment right then? Why wasn't he locked into a facility right then from the military?
Mr. McKenna, you testified the VA counselors and parents advocate in your written testimony were unable to provide clear guidance on your care options. How do you think VA needs to fix this?
Chairman, if I understand the question correctly, it talks about the dichotomy of the two experiences I've had. First, when my wife and I retired, we moved to Northwest Florida, specifically in the Pensacola region. Very similar with respect to services as it is in Eastern North Carolina, meaning the main VA hospital center for Northwest Florida is located in Biloxi, Mississippi. That's about 2.5 hours from our home. Same situation when I went to the VA clinic in Jacksonville after relocating a year later in Eastern North Carolina. The main VA clinic is in Fayetteville, North Carolina. That's, again, 2.5 hours from my residence in Richland, North Carolina. These two VA clinics, both in Pensacola and Jacksonville, North Carolina, are completely different in the fact that, one, the process in Pensacola, Florida was seamless. The quality of care I received from that VA clinic, from meeting with Dr. Sandoval and his team, to talking to VA counselors in the network, community care network, to actually seeing providers out in the community. That entire process from flash to bang was about 10 to 15 days, depending on what that specialty care was. Conversely, in Eastern North Carolina, same specialist care I need. One, I can't be seen at that VA clinic by either a doctor or a nurse because they don't have that capability or capacity there. Additionally, they're not taking any new patients. So they, in turn, set me up with care in the community to a clinic, a Med-First clinic. It's a primary and an urgent care clinic. Only thing on staff there are nurse practitioners. No doctors, no nurses. Good people, but probably been from drawing your blood to basic medical care like a flu shot. It's beyond the scope of their capability. They, in turn, will put a referral in. Now, unfortunately, they have to use a third-party vendor to do this. A third-party vendor puts that referral into the VA, again, delaying the process. I think to answer your question more directly, the friction point in Eastern North Carolina lies with the third-party vendor. There appears to be no oversight either from the VA or from Med-First. When I tried to advocate for my own health care by saying, hey, can I get an email or a phone number to talk to this third-party vendor, I was told both by the VA and Med-First that they're not authorized to provide me that information, to be able to communicate, to understand why this process is taking so long. And then finally, when you do try to, or at least when I try to understand what is causing these delays, and when you talk to the VA counselors, either on the telephone or through My Healthy Vet online, I get responses like, hey, that's just the way it is here, or we didn't receive the required paperwork from your primary care provider out in town. Now, to the latter statement, I personally watched that nurse practitioner at Med-First in Richland, North Carolina, fax that form to the VA. And then when I followed up the next day, having a fax receipt of that, I was basically told, quote, I don't know what to tell you, end quote. So again, sir, to answer your question more directly, more oversight on that third-party vendor, and then better training and education to the VA workforce that works the community care network.
Thank you. I'm way over time, but Ranking Member, you're recognized for a minute.
Well, with that, Mr. Chairman, I'm very glad to hear that you intend to hold more oversight hearings. And I hope you do that before we rush a bill to the floor that purports to be a solution. And who's precisely missing on this panel is the third-party administrator and anyone from VA. So I want to change my question to Ms. Saindon. I find it curious that my majority counterparts want to see VA function more like a private sector actor, but they force VA to abide by standards that no one in the private sector would ever accept. For example, can you imagine that United Healthcare would pay claims without receiving a patient's health record or any proof of medical necessity? And yet, through the third-party administrator, in this case Optum, which is in reality United Healthcare, renders payment on behalf of VA without requiring their providers to transmit veterans' medical records back to VA. Now, Dr. Saindon, do you think that VA's contracts should require network providers to submit medical records as a condition of payment?
On behalf of the membership at NOVA, yes, absolutely. We've discussed this ad nauseum. It's a huge threat for good coordination of veteran care. We are aware that the next generation of the contract is imminent, and we strongly advise Congress to consider modifications to that, where payment is issued upon receipt of those medical records, and we have countless examples of how healthcare has failed those veterans as a result of not having those medical records readily accessible.
Thank you for that answer. And again, I would point out that Optum, otherwise known as United Healthcare, is not here. They were given a pass for not being here, and they are an accountable party, and they're a third-party administrator. I hold VA accountable also for not having contracts written so that this is part of how you do business. But VA is forced to operate not as a private sector company would not think of operating. Right? That we would, any private healthcare network would make this a condition of reimbursement. How does not having these records affect VA's ability to properly coordinate veterans care?
Countless ways.
Yes.
Yeah, significantly. It poses a real threat to good coordination of care. A good example of this is a veteran gets referred out to a community network provider as a result of a specialty that they may need and have a follow-up with a primary care provider a week later, 2 weeks later, whatnot. The veteran's information yet has still come over to the VA from the community provider. So that puts the VA providers in a real problem situation, unable to determine what recommendations, what were the treatment plans, et cetera.
Yeah, so I would have loved to have VA and United Healthcare here to explain why this has gone on and why it continues to go on. So there are kinds of care that, Dr. Saindon, that private sector care is simply not equipped to provide. They're just not going to invest the money or the resources or research into it. It's unwilling to provide because there's no profit to be made, no profit. So that's why the public backs up our veterans when the private sector is just, there's not the incentives to do it. For example, VA has invested billions of dollars to provide care for veterans with complex spinal cord injuries, traumatic brain injuries, limb loss, and prosthetic needs. What will happen to this very specialized care if we continue down this path of community care expenditures outpacing investments in the VA direct care system?
So community care for these specialized services that you just mentioned are just simply not available, more so in the rural settings, and the care is not comparable. And if there is a scarce resource in the community for that specific specialized care, it's too finite to take care of our veterans adequately.
Well, thank you. You know, in your testimony, you highlight the anticipated national shortage of primary care physicians that the national healthcare system will face in the coming years. That's not just VA doctors, but the national. Can you elaborate on why this makes it more important than ever to invest in a strong direct care network at VA?
So NOVA is incredibly proud of our educational mission. We train 70% of healthcare professionals nationwide. In other words, if you ask a healthcare provider if they've had any type of training or stepped foot in a VA during the course of their training, you will hear a lot of the yeses there. Our goal is to grow our own, maintain those trainees, support training the healthcare infrastructure as it relates to providers, and robust scholarships, incentives, continuing education opportunities is a way that we could incentivize that, and NOVA strongly supports considering those options.
But not having a strong direct care network at VA will definitely impact the training of our future professionals.
Absolutely, we've already seen it. In fact, there's gross shortage of educators in the healthcare industry, as well as preceptors and the front lines in the field, limiting our ability to take student trainee placements. And if we continue to struggle budgetary and or with veteran care, access to veteran care, we will have to continue to limit our capabilities of taking trainee placements, which will ultimately collapse healthcare.
Thank you. I yield back.
Dr. Murphy.
Thank you, Mr. Chairman, and thank you all for coming today. Thank you for the service to your country. And these are some real difficult stories to hear from somebody who has taken care of VA patients for 35 years and actually continues to do so. I find it somewhat ironic that the ranking member brings out the stories that we're talking about the failures of the VA over the last good Lord, I don't know how many years, but especially over the last administration, where they continue in an electronic medical record system that is outdated, incompetent, inefficient, doesn't communicate. And I can say this on the front end and the back end. It doesn't cost a penny for me to click a button and send something, a medical record, as a community care provider to the VA. It doesn't cost a penny. We do it all the time when we communicate with all the other doctors. So that's not true. It's not anything has to do with profit. It has to do with the fact that we have an inefficient organization that is becoming more and more inefficient. And I'm so optimistic that with the next administration, we're going to crack it down and actually make it like a private organization would be, efficient, and for the people who actually should benefit from this, our veterans. You know, I've said this many times here, I have veterans show up and I have no records in front of me, nothing. And I'm community care supposed to take care of them. Community care exists because the VA doesn't have the medical expertise or the physicians to take care of it. We have our national institutes that govern our medical schools now, which are absolutely being negligent in how they're creating doctors. So this situation's not getting any better. It's going to get much worse. And as specialties occur, the VA, I just tried to get on a website here to see what urologists were needed in the VA. They're all over the place. And if a veteran needs urologic care, they're either got to not get it at all, or they're going to have to go out into the community. It's just a fact. And specialty care, as I've said this before, costs more than other care. Anyway, enough of that rant. You know, I'm happy. I'd love to see United Healthcare come in here. I would love to see that. And I look forward to that day, because they're killing people out in the regular community, and they're by denying care, and they're doing the same thing with our veterans. So the third-party stuff, I'm looking so much forward to creating some true efficiency within the VA. Sergeant Major McKenna, thank you for your service. Welcome to, I love, Eastern North Carolina. We got a little snow today, by the way, out of the blue. I want you to tell your experience, because you were in Florida and you thought you had an efficient community care system. You've come to North Carolina and it's not. Can you tell me the pros, cons, what you think that is all about?
Thank you, Dr. Murphy. And just to pile on your point, if I may, what would further assist the VA is building that electronic bridge with respect to medical records from our service members, whether they do 4 years or 40 years. They'd be able to have those VA doctors and even the care in the community doctors access Alta or other VA medical and dental records would, again, bring us into the 21st century.
Yeah, I've gone on about how broken the system is.
Yes,
and how
sir.
it continues to be inefficient. Please
But back to your question, sir. My wife and I initially resided in Northwest Florida upon my retirement in 2021. And there were several factors that drove us to that geographical location to retire. Number one, my wife, Michelle, who's a federal employee, took a job in government service at Naval Air Station Whiting Field in Milton, Florida. Number two, the quality of cardiac care in Northwest Florida. Michelle received a mechanical heart valve after being diagnosed and treated for endocarditis in 2013. And then finally, the word from my fellow retired Marines that the VA healthcare system was first rate in that location. Michelle's health care is covered by TRICARE for Life. As you all are well aware, that insurance...
Sergeant Major, I don't mean to interrupt, my time's limited, but if you can talk about the 6 months versus the year
Oh,
referrals
absolutely,
that we
sir.
get.
So the process, and I think I already alluded to it in an earlier statement, that in Pensacola, from seeing a doctor at the VA to getting a referral to be in care in the community to being actually seen in the community, 10 to 15 days. Conversely, Eastern North Carolina, to seeing a doctor, not at the VA, out in the community, to getting a referral, and I'm talking about for specialty care needs, TBI, mental health, orthopedics, urology. I am waiting personally 9 months still for that referral to be approved. Let me repeat that. I'm waiting 9 months for that referral to be approved. Now, my fellow veterans in Eastern North Carolina, this story is not unique. We're talking 6 to 9 months to get any type of specialty care in Eastern North Carolina. Despite my best efforts to advocate for my health, contacting the VA advocate, those calls go unreturned.
I've got to close up with my
Yeah.
time, but the bottom line is, my understanding it is, the bureaucracy is not allowing you to see the doctor when in a timely fashion. And as Mr. Dooley has shown us, that can have up to lethal consequences. So thank you for your service. Thank you for your testimony. Mr.
Thank you,
Chairman,
Dr. Murphy.
Ms. Brownlee.
Thank you, Mr. Chairman, and thank you to the panel for being here and sharing your stories. And I'm, deeply sorry that the VA did not provide the services and the quality of health care that each and every one of you, and Ms. Locklear's in your son's case, that they earned and deserve. So I'm sorry to hear that. I have to say, I've been on this committee for 12 years, and for over that 12-year period, I've heard over and over and over again that a very large percentage of veterans say they prefer receiving their health care at the VA over community care, and they believe that the quality of care within the VA is very good and in some cases superior. So what we have to kind of wrestle with here on the committee is the more we invest in community care, the less we invest in VA care. And I think, we have been wrestling with that, and we need to continue to find where that balance really is. And I believe in community care. For 12 years on this committee, I have advocated for better equality for health care for our women veterans. Women veterans have to receive a large portion of their health care outside of the VA. So it's clear that to provide those services to our women veterans, we have to have community care, and that's a true phenomena in, beyond one population, meaning women veterans. So, I think in many cases also that wait times are largely longer in the community than in the VA. Now, I know, Mr. McKenna, you've talked about the processing and the sort of the bureaucracy that goes on, and I think that is certainly part of the problem when we talk about longer wait times in the community. But it is also true that in most circumstances, wait times in community care are they're just simply longer. It's just a fact. So the way I see it, the facts that I see is that, and although every VA is not the same, and Mr. McKenna, you've pointed that out, or was it? I'm sorry, Mr. Dooley. Were you the one that said you got good health care one place and not so good? Or
That was actually Mr. McKenna.
Mr. McKenna. So Mr. McKenna has pointed that out, that not every VA is not the same. But if you receive health care in the VA, I think this is a fair fact to say, that if you receive health care in the VA, it's usually quality care. The care is also less expensive. The National Bureau of Economic Research recently came out with a working paper that found that VA also reduces total spending by 21% relative to non-VA providers. So the care is less expensive in the VA, and if we invest more in the VA, wait times will improve, and it's what the veterans want. They want the larger percentage of veterans, they want their health care within the VA. So I think that's, in essence, what we kind of have to wrestle with here. Where is the right balance? But I think it's, I don't know whether all of you are advocating for, it sounds to me like you're advocating, I'm not sure whether you're advocating for more community care or better community care. I'm not sure which one it is. If it's better community care, I'm with you all the way. If it's more community care, I'm not sure that we have found the right balance. So that's kind of where I am. And so, Ms. Dymond, can you just respond to what I've just said?
Absolutely, and thank you for the question. I would say absolutely better community care. There are many holes which have been illustrated by the panel and including myself, and I think there needs to be more meaningful effort put behind how veterans are assisted in accessing that community care. A lot of the pressure is put on the veteran themselves to do the work. So we were handed off to, speaking for myself, I've been handed off what I've illustrated here and in other experiences, interactions I've had with community care, where an overwhelming amount of the pressure is put on me to figure out what care I need and find the correct providers, because VA is not doing it on their own. It's really tough. So better, absolutely.
Well, my time is out, but I will just say, Mr. Chairman, I'm happy to work with you to improve the process by which we get veterans
And
to
that's what-
community cares when we need it. I'm not willing to have a large conversation about just increasing community
That's not what the
care.
conversation is. The conversation is providing the best for our veterans and doing it correctly. And right now, the system is broken, and we've got to fix it because of things like this. But it is a quality. And the thing is, obviously, BVA getting paperwork right and all of that. But we've got to quit arguing on whether it's where I'm right or you're right or who's Republican, who's Democrat, and start arguing for the veterans. And that's what we're trying to do. And I have told, and I will tell you this, we'll also bring the other ones that the ranking member has asked for. And to say that we didn't bring them in because we were trying to do some kind of ridiculous thing about arguing over the community and over VA, I think that what we have to do is make sure the veterans get what they want, when they need it, where they need it, at the level that they need. And I agree with you that there are a tremendous amount of people that have a tremendous experience at VA if they can get when they need it, and if I'm not traveling 5 hours to get there. So we've got to keep working on it together. We can't just all of a sudden say, well, you believe this and you believe this, and we've got to start working on it together. We've got to.
I believe we have to work on it together too, but I think we have to have more hearings around this.
I got
and
it.
Debate a lot more issues
I got it.
around
And-
it,
and
make
when-
sure that we're working off common facts.
And when our staff writes our script, maybe what they should also pay attention to is the fact we are trying to work together and quit trying to make it look like it's a partisan act. Just saying. So,
I yield back.
all right. Mr. Hammond.
Thank you, Mr. Chairman. And as a veteran, I understand the obligations we owe to our fellow veterans. Now, President Trump got it right when he signed the Bipartisan Mission Act, putting veterans in charge of their health care decisions. Yet today we're seeing bureaucratic roadblocks that prevent veterans from accessing timely care, especially with mental health services. Now, the stories we heard today are deeply troubling. I want to commend President Trump's incoming Veteran Affairs Secretary, Doug Collins, who many here know him very well when he served in Congress, for his commitment to accountability at the VA. But we must do more to ensure veterans can choose where they receive care. The VA system should work for the veteran, not the other way around. When a veteran needs help, they shouldn't face a maze of prior authorizations and arbitrary denials. The data is clear. Expanding community care access doesn't increase costs. It increases quality. We must codify access standards to guarantee veterans' rights to seek care outside the VA when needed. But I want to thank all of the witnesses for coming today and for their service and for sharing your brave stories as well. Now, Mr. Dooley, my first question is for you. You waited 9 months for critical treatment. And if you could redesign the VA's authorization process for veterans seeking urgent care like cancer treatments, what specific changes would ensure veterans get immediate access to the nearest qualified provider, whether VA or community care?
I think to start that off, the first thing would be to know how fast they can get it from the VA. That's the first thing to know, and inform the veteran of that, of when they could get that treatment. And the second would be going into community care, if that's the route that they decide to go, being able to reach out to different community care providers and finding what amount of time that they could actually get it done in. In my case, if it could be done in the VA in, say, 3 months, that's too long. Let's see what community care can do. And then if community care is 5 months, obviously the service member being allowed to know that and then make a choice. But then also going back and seeing what other care providers may be available that could get it done earlier. That would provide me with the earliest treatment I could, and then also the knowledge of knowing which one would provide that so I can make an educated decision.
Thank you. Now, would you support eliminating prior authorization requirements entirely for certain urgent medical services, similar to how we handle emergency care?
Without knowing the full specifics of that, I can't say that I would recommend one thing or the other, but what I could say is I would have liked the opportunity to cut through the red tape and allowed to get my screening prior to that. It could have made all the difference. So if anything that would be cutting through the red tape and getting the service member to that type of treatment prior, or as soon as possible, I would recommend.
Thank you. Now, Ms. Locklear, you witnessed firsthand tragically how delays in mental health affected your son's trust in the VA system. Now, shouldn't veterans have the immediate right to seek mental health care from any qualified provider in their community without jumping through bureaucratic hoops?
Yes.
And how would this have impacted your family differently if that were to have been the case?
Well, Logan did that. I mean, he took it upon himself to get the care that he needed because of his distrust in the VA. But unfortunately for Logan, I think he got a provider that she just continued to prescribe him medications. And he was so desperate to get better, to honestly get better. And so I think she was over-medicating him. And I found out recently, just a few days ago, I knew he had went into the ER, and I found out he was in the ER because he had lithium toxicity. She had put him on lithium, and when I spoke to my pharmacist about it, they said, Lori, that's a dangerous drug. It's old. I can't believe it's even being used. But he was on it, and he had to go to the emergency room because it became toxic. But I would like to say something in regards to what you're already saying, if you'd let me do that. 60 days to get community care okay. But when Logan checked in, and by the time it took community care to sign off on what he needed, was 2 days prior to his death. Well, in those 2 days, he still didn't get called. So, and at the time, when COVID came in, we had staff that left our hospital to went home to work remote. They never came back. They worked from home the entire time, still working from home. Trump telling the employees to come back to work, they need to come back to work. I don't know that didn't take part in why it took 60 days for someone to look at my child's chart and say, he's already tried to commit suicide a number of times. He's depression. We might need to go ahead and get him taken care of as soon as possible. That didn't happen.
Thank you. Mr. Chairman, I yield back.
Thank you, Dr. Conaway.
Thank you, Mr. Chairman, and thank you to the witnesses for bringing forward their experiences for the edification of this committee. We, as a nation, should be deeply grateful for the sacrifices that our veterans have made on behalf of all of us and their families have made on behalf of all of us. And as a physician and veteran myself and someone who spent the last 25 years trying to figure out how to expand access to quality care in my own state of New Jersey, as I listen to your testimony, I can easily point out the many failures on a bipartisan basis that have occurred in advancing access to quality care for members of our society, and it's particularly troubling and concerning when we're seeing these problems among our veterans to whom we owe so much. There are failures to invest in the technology that will allow us to understand what's going on. If we don't understand data about who's being seen, when they're being seen, what paperwork and information that needs to flow from those experiences so that care can be examined and improved, then we are failing. And this is, anytime you put more and more bureaucracy in a situation in healthcare, and we see this all over the place, whether it be prior authorizations, which has been mentioned, all of this paperwork flowing back and forth. Someone goes to see the physician, they get a referral, they follow up to make sure that referral is taken care of. You don't need a lot of technology around that. So this idea of exploring how we get rid of all of this paperwork and all of these hurdles is certainly a very valuable exercise, but understand, as I hope everyone in this room does, that these hurdles have been put in place because of a concern about the spend. Every person who works in healthcare, every person who receives a service, there's a dollar behind that. And so our concern, right concern, about how much we're spending in a particular line item for veterans health care, depending on what our priorities are. And again, in my view, the Veterans Administration has not been properly funded. It has not it does not have the staff it should, and that says, in my view, that we're not paying the kind of attention we need to pay to the veterans who deserve our thanks. I am concerned, as has been raised here, that we don't have, and we're going to have more, and I take the chairman at his word, that we're going to have additional hearings on this, because we certainly need to see and hear from the TPAs that are managing this healthcare. We certainly need to hear from the VA about their processes and what they plan to do about these very troubling things we've heard today. We need to hear from the Office of the Inspector General about their review of the situation and what we can do to ensure that the data is made available to us so that we can actually know what's going on and where the failures are. Every time we have applied data, whether it's in the financial services, sending people to the moon, developing the latest technologies, it's all developing the right plans for healthcare so we get the outcomes we want. It's all a data-driven process. And we sit here today with a very disturbing lack of the kind of data we need to decide actually what's going on. I'm very sorry, ma'am, for the tragic loss of your son. It is, you don't need to have children for that. I happen to have a couple of kids. I can't imagine the pain of losing a child, particularly when you did so much to try to protect that child as parents do. We have heard from the administration that there is a hiring freeze, and I've heard from perhaps some or all of you that there's a real concern, and certainly Ms. Saindon, about the staffing shortages there. People need to power this system of care. We understand that. And it has been years that it's been recognized that we don't have enough staff in the VA, again, because of our lack of investment, on a bipartisan basis, by the way, in the VA. And so, can you shed some insight on how this hiring freeze will impact a situation which is already dramatically problematic, and which, if it continues, will prevent the kind of improvements that need to be made to ensure that veterans get the care we need. So discuss the hiring freeze in the context of the current staffing shortages that we have and the difficulty that it will bring to making the kind of improvements that clearly need to be made in the provision of care through the VA.
Thank you. The hiring freeze was shocking yesterday for many of our membership. There's already been conversations as to what we can do to advocate to respond to this. We are grossly concerned about the impact it will have on bringing in new nurses, bringing in new providers, also the reputation for the VA. So these individuals, from what we understand, the membership, individuals that had been selected and or were in the process for recruitment received automated messages, and that's not the way we do business in the VA. We like to have conversations with our candidates and our applicants, and yesterday they got automated messages from the platform we use in VA USA Jobs saying that the position was rescinded. So we're concerned about our reputation to continue to get the most qualified individuals within the VA system and maintain them. Inability to continue to staff at our ceiling levels or at our approved levels within budget will impact our ability to provide inpatient care. It will impact our ability to maintain clinical access, and it will be a continued need to coordinate care in the community, which is a threat also, because that's a heavy, laborious process that requires more staff from the VA to support the coordination of care in the community.
I don't know if anyone wants to answer. That's my time, Mr. Chairman. I don't want to go over it, but if you permit anyone else to answer it, I'd certainly appreciate that, and I'll thank you for the time.
Thank you. Mr. Self.
Thank you, Mr. Chairman. On behalf of the veterans across America, like my constituent, Mr. Dooley, thank you so much for making the trip to be here with us and tell us your story. I'm ready to turn the page to a bright future. That last questioning we are going to right-size this stuff, and we're going to get it right. And I'll leave it at that. Thanks to the Trump administration, we are going to be able to offer our veterans a helping hand after 4 years of cold shoulders, failures, and broken promises from the Biden administration VA. It's unforgivable that the hardworking Americans who served our country honorably paid the price because VA employees choose to serve bureaucracy rather than our veterans. There is a new sheriff in town, and I assure you that I think the changes are coming. Mr. Dooley, in this committee in the past, I always make the point about the VA wants to talk about inputs. We started this new program, we spent this new money, we did this. They never want to talk about outputs, and I want to thank the 4 of you for coming to talk about outputs in the VA system, because that's what this committee ought to be talking about, outputs. So, Mr. Dooley, it took you 9 months to receive a colonoscopy. What do you think that did to your body over 9 months? Any ideas?
Mr. Stoff, I am not a doctor. However, I do know time matters, especially when it comes to cancer. And I know that from stage 1, my possibilities of surviving and remaining a long life with my children drastically goes down when it goes to stage 3. Stage 1 to stage 3 is literally it got the mass got big enough and it got into my lymph node system, making it stage 3. At that case, it's a lot better possibility that it'll move to other parts, and even if I am cancer-free now, the chances of it moving on and coming to another part of my body is actually a lot greater. So to answer it very shortly, my life and my chances for remaining and living a longer life got reduced by those 9 months. Could have taken years off of my life.
I understand. So what broke through after 9 months? What broke through to your treatment?
Me waiting. Unfortunately, I waited 5 months for the appointment, and then once I found out I had cancer, they said to wait another 4. And to be totally honest, your office is the only reason that I got seen.
I want to stop right there, Mr. Chairman, and say our veterans should not have to have their member of Congress be the first line of defense with the VA. That's my most important point today. The member of Congress is not the first line of defense to get an appointment. And yet for my constituent it was. So that to me is a crucial point in this hearing. The system that you encountered, Mr. Dooley, do you think it was designed to help our veterans or to put up obstacles and barriers to actual care?
From what I personally experienced, it looked like it was they made incompetence absolutely vulnerable for the area. I saw a lot of people that didn't do their job, and there was no way to hold them accountable for it. That was as simple as I wasn't even given a name and a number to call back. The number that I would call back would be a hotline, and then I couldn't even leave a message for that person. My written testimony doesn't have a lot of names in it, and definitely doesn't have any direct numbers. There's a very good reason for that. It's because I wasn't provided any. It's really hard to hold somebody accountable when you don't even know who they are.
With that, Mr. Chairman, I think those are excellent points, and I yield back. Thank you.
Dr. Morrison.
Thank you, Mr. Chair. My sincere gratitude to our witnesses for joining us today. Thank you to you and your families for your service to our nation. I'm glad to be here with all of you today for our first committee hearing of the year and my first as a member of Congress. I'm honored to serve on this committee because military service runs deep in my family. My husband John and my father-in-law are both combat veterans, both former proud Army Rangers. My dad and my grandfathers all served as well. I firmly believe it is our duty here in Congress to provide our veterans with the resources that they deserve and have earned. I'm a physician by trade. I'm one of the 70% who received some of my training at a VA. And having had the opportunity to care for these brave men and women, I take seriously our congressional oversight responsibilities on this committee and look forward to working in a bipartisan manner to ensure that VA provides the highest quality of care to our veterans. Now, I'm admittedly new to the committee, but it strikes me that we both need community care and we need better oversight of community care. It also sounds like we need to invest in a new EMR. And honestly, as Dr. Conway referenced, we are grappling with the same workforce shortages that many sectors of our society are facing. So I'm concerned about the hiring freeze that you just discussed. Dr. Saindon, as you know and referenced, VA clinicians are particularly well equipped to treat conditions that frequently affect veterans, such as PTSD, substance use disorder, and traumatic brain injuries. Are there currently standards in place to ensure that community care providers are adequately trained to treat these types of conditions?
This is another frequent topic of discussion among NOVA membership. To our awareness, there doesn't exist community indication of competencies, training, or quality. And it's concerning that we entrust those providers in the community with our veterans unaware of those data points.
So thank you for that answer. I assume then that you're concerned that the lack of training and educational requirements may threaten the standard of care that a beneficiary may receive outside of the VA?
Correct.
Thank you. Thank you, Mr. Chair. I yield my time.
Thank you, General Berkman.
Thank you, Mr. Chairman, and thank all of you for being here. This has been a long hearing when you have the break for a vote, so we just appreciate your patience. And in life, you got to be patient. But you got to be persistent. You have to persevere. All of those things. And some of us who've been on this committee for a while are, I'm not going to say getting a little long in the tooth, but we're definitely getting a little frustrated, okay, over the lack of movement of the bureaucracy. During the 115th Congress, those of us who were here, it was when the Mission Act was crafted. Now I'm going to use a visual example. So we put the Mission Act into play. And since then, anybody here not know what the game whack-a-mole is? Okay? That's what it's been, because from the committee standpoint, and even I would suggest to you from the veterans standpoint, you hit one mole and it goes down and another one pops up. It's a moving target. It's such that in our roles and responsibilities here, we owe it to the veterans, and we owe it to the doctors and the nurses, all the healthcare providers in the VA system to actually eliminate the whack-a-mole nature of this so the care can get right to the patient. So what we have seen is that the mid-level bureaucrats in the VA have prioritized, to a great extent, the bureaucracy over the veterans themselves. They're focused on, well, let's adjust this process, or let's do that, or that, without concern that the end game of providing care is not there. So we haven't talked about today, and then I'm going to ask a couple questions here, is that because there's an assumption if you live in an urban or suburban area, you either get in your car, get in the VA service officer's van, get in an Uber, get on the transportation, and go to your local veterans, hospital or wherever the clinic is. Well, we got rural and remote in our country too, and especially add a snowstorm. I got a hunch there's probably nobody in South Carolina today on the road. Now, in Michigan, with a snowstorm, they're still going to go on the road to get there, okay? But we have the whole spectrum here of the urban, suburban, rural, and remote to provide the care. So, Mr. McKenna, just a quick reaction here. Was your reaction when you discovered that VA counselors were unfamiliar with the basics of the Mission Act? By the way, in polite Marine terms.
Thank you, sir. And again, to use your analogy of whack-a-mole, I think if you go back to the Mission Act itself, and to prevent knocking things down that you've already hit before with respect to training and education. Training and education must happen continuous.
So I'm going to cut you off.
Yes, sir.
Because my time, as you know, as Marine here, we're not going to waste time. And you absolutely right. So don't waste time. We waste enough money. You can recover money, but you can't waste time once it's gone in veterans care. But do you think, when you mention training, that the VA employees should be required to undergo periodic training and updates to familiarize themselves, in this case, with the community care program?
Yes, sir. And I'll give you one small example. If you ask a VA counselor, at least my experience has been, can you give me any elements of the Mission Act, specifically care in the community? And and I'm talking numerous people, not just one, are completely clueless to this legislation. If that's not an indictment on the VA and their training and education program, I don't know what is.
Yeah, and it's an indictment, quite honestly, of the leadership, especially in that at mid-level. Why is the United States military so successful, regardless of service? Our staff NCO Corps, our NCOs and our staff NCOs. It's got nothing to do with the officers. It's the staff NCOs, and those mid-level folks within the system is what is going to make it work, and that's where I believe we need to focus bipartisan, because it's not Democrat or Republican. It's about getting the care, and it's about retooling, if you will, the bureaucracy. I didn't say eliminating it, retooling it so it actually functions in a 21st century world with electronic health records and all of that data sharing. And with that, I yield back, Mr. Chairman. Ms. Ramirez.
Thank you, Chairman. I want to start by thanking our witnesses. As you heard from other colleagues here, I know that between the votes and coming back, the schedule was a little difficult, but I want to thank you for being here. I want to especially thank Ms. Locklear for your testimony. I want you to know that your sharing and the pain that you feel was felt by every member here. I want to thank you for your courage to be here and to speak truth to the experience that you've had and the experience you don't want any other parent to have. So I just really want to thank you from the bottom of my heart. And one of the most pressing issues our veterans are facing is that quality health care, is that access. And it's a concern shared by so many everyday Americans really trying to navigate our system of privatized care. In hearings like today, I think it's important that we reflect on some of the assumptions that we're making. You know, I assume we're committed to meeting the healthcare needs of every single veteran. I want to assume that caring for every veteran means providing them the full spectrum of services. You see, I assume we want our veterans to have the best, the most comprehensive, the most coordinated, the most timely, and the most accountable healthcare we can offer them. And I want that for every veteran. Frankly, I want that for every American. I assume we mean the same thing when we talk about community care, but I am learning that we mean different things, and some of my colleagues just mean private care. Finally, there's another assumption operating of which I cannot get behind, and that's increasing access to private care that would automatically result in better healthcare outcomes for some veterans, but not the others. The evidence shows that public VA facilities provide higher quality, veteran-specific care. But if you believe that the private sector can do it better, which I don't, then you may be comfortable with the concerning amount of money being funneled away from the VA into privatized care. And folks, I'm concerned that we're not asking whether that care is really leading to healthier and better outcomes. Because choice alone is not the point. We want choice, but we also want quality, and that's what we should be after. As we've heard from many of my colleagues, there are instances when our veterans cannot access a VA healthcare center due to distances or due to other barriers. However, the VA healthcare system is set up specifically to address the needs of veterans. So, Dr. Saindon, did I pronounce it correctly? Good, good. Pronunciation is important for me. Can you tell me how the VA healthcare providers and clinicians are uniquely prepared to care for our veterans? I specifically want you to tell me what trainings are required for you to take to ensure that you're providing culturally competent care to our veterans.
Every employee is required to do military competence training In addition to that, based on the occupation or based on the role of the healthcare provider at the VA, they have a whole slew of different trainings that are specific to meeting the needs of those populations that they serve in that role specific.
And Dr. Saindon, let me ask you a follow-up question to that. Are community care providers required to take those trainings?
Not that we are aware of.
Additionally, are there third-party administrators who manage a network of community care providers required to ensure that providers in the network complete these trainings?
Membership has spoke about this several times. It's in our written testimony. We're very concerned that there is no such requirement.
Got it. Thank you, doctor. Look, community care is part of the equation that we need to be discussing today. And yes, we certainly need to do everything in our power to ensure our veterans are receiving care, but we need to make sure that that care is high-quality care in a timely manner. Veterans have the best, the most comprehensive, the most coordinated, the most timely, most accountable health care. That's what we need to be working towards in this place. And so as we discuss this conversation today about community care, as we talk about the impact that our veterans are experiencing every single day, as we talk about their own families, I truly hope that choice and quality are going to go hand in hand. I want to thank our witnesses here today. I want to thank the chairman and the ranking member and the vice ranking member here today as well. I look forward to having a fruitful conversation over the work that we do over the next few months, where it's centered on our veterans and their care. Thank you. With that, I yield back.
Thank you. Mr. Van Orten.
Thank you, Mr. Chairman. I appreciate being here. I'm very sorry I had to step away. This place pulls you in 50 different directions, but I've read all your testimony, and I want to thank you for coming out here. I spent my first day in Congress calling the widow of a veteran, the brother of a veteran, and the sister of a veteran, sister-in-law of a veteran who committed suicide because he didn't get a mental health consultation. I printed that letter. It's been sitting on my desk for 2 years, and it's got a note on there. It says, "This is why I'm here." I've learned a couple things. I chair a subcommittee. I learned a couple things over the last 2 years. This is the first Congress, I've been in Congress for 2 years and 5 minutes. I don't want to hear from the VA right now. So our ranking member said, "Why isn't the VA here?" You know why? Because they don't tell us anything. I've essentially had 10 of the same damn hearings with these guys because nothing changes. No one's held accountable at the VA. Nobody. Check this out. They made a $25 million estimate to do the digital GI Bill. It's going to be $1 billion. 25 million to $1 billion. No one's being held accountable. The Cerner trash, I just got off the phone again with 2 doctors. I just want to check civilians who are using this. Cerner was sole source to contract to do the electronic medical record. $16 billion, they spent 14, they want to do 18. They're saying and they had to delay it to 2026 because it doesn't work. $14 billion into it. You know how much they say it's going to cost to get it across all the visits? Take a guess. I'll tell you, $50 billion. No one's being held accountable. Mr. Dooley, I'm terribly sorry, and I'm going to formally apologize to you from the federal government. I'm so sorry. Let me ask you something, Mr. Dooley. Has anybody that had anything to do with the travesty that has taken place in your life at the VA been held accountable? Anybody?
To answer shortly, no.
Ms. Locklear, my heart breaks with you. It does, and we talked, and I thank you for that. We know what it's like. I know what it's like to lose a child. And I don't know where you'd be and how you hold up with this grief, knowing that it was much more preventable than the loss of our daughter. To your knowledge, has anyone been held, excuse me, your son, I apologize, it was our daughter. To your knowledge, has anyone been held accountable at the VA?
No.
Nobody. Ms. Murray, to your knowledge, has anyone been held accountable for dragging you around and treating you like a hobo who's begging for help for injuries And PTSD is an injury. Has anyone been held accountable for treating you like a beggar and kicking you around the country?
None to my knowledge, sir.
Okay. Well, I personally am looking forward to our new secretary, Collins, getting in here. And the people that are responsible for these billions and billions of dollars of waste are held accountable. Because every single dollar that is wasted is a dollar that can't go to making sure you can go to a program in a different region. To making sure, sir, that when the VA cannot possibly help you, that you go immediately to community care, and that you don't have to have 57 different referrals for the same treatment plan. And ma'am, to make sure that no mother or father or brother or sister ever has to find their child in a bathtub after they've committed suicide because they didn't get the mental health care that they needed. And I know that the men and women on this committee mean what we say. I just believe that some of my Democrat colleagues are misguided. I get all my health care through the VA. I'm a 100% service-connected disabled veteran. I get all my health care through the VA. The people that treat me in La Crosse, Wisconsin are fantastic. That's from the people that are checking me in to my primary health care. I'm so proud of them. In Toma, Wisconsin, I'm so proud of them. Do we have problems? Yes. But the farther up the chain we get, the farther away from reality we get. And I want to have some of these people that have been sitting in these offices at the VA collecting a paycheck go out and talk to you, ma'am. I want them, sir, to go to a medical appointment with you and your family and let them explain to you and your family why you couldn't get the health care you needed because they're too damn lazy and they're more concerned about protecting your bureaucracy than the veteran. That's what needs to happen. And nothing's changed until it does. And that's what we're going to do under the new secretary's leadership and the leadership of this chairman. That is my promise to you. I yield back.
Hey, Dr. Milwakes.
Thank you so much, Chairman Bost, for this hearing. It's interesting, my conversation and my thoughts as we've listened to this hearing and listened to both members on this side of the aisle and the other side of the aisle proffer questions. So my questions are different now than they were when I first came in here. First, Sergeant Major McKenna, my family, my husband's family is all from Richland, North Carolina, and I know that system well. Ms. Saindon, you mentioned about everything being automated and how concerned you are. Let me just say that I applied for a job as a physician. I'm a nurse and a doctor. Applied for a job at the VA in 2014. All of my responses were automated, so I'm not sure how that's not how we do things at the VA. And as I recall, the president at that time was President Obama. And all the responses were automated and went through USA.gov. That's one of the issues we have with hiring. And the 4 years that I have been on this committee, there has not been a lack of funding to the VA. As a matter of fact, funding has increased every year. And even in this hearing room, we had a hearing on mental health care and suicide prevention. I, as the chair of the subcommittee on health, and through that hearing with the VA present, found out that the VA did not consider residential mental health care or substance abuse disorder health care to fall under the Mission Act, and therefore they did not have to get somebody in, a veteran in, within 30 days. Now, as a nurse and as a doctor and a person who has family members who had PTSD and mental health issues, if you're at a point where you think you need residential care for substance use disorder or mental health, you need mental health care now. And we put forward a bill that it had to be within 10 days. The first bill that I passed and had signed by a president in 2021 was Brandon Concerta, who 5 hours after he visited the VA in Iowa City, which is an excellent VA, committed suicide. And as a nurse, and as a doctor, and as a veteran, but most importantly, as a mother, Ms. Locklear, we feel that we are responsible for our children's happiness and success, and I know the burden that you bear, and it is not your fault. And it is the responsibility of this committee and members on both sides of the aisle to make sure that what happened to your son does not happen to any other sons and daughters. And that's why you're here today. Ms. Saindon, does the VA send veterans to get care at VISNs far away from where a veteran may reside?
To my knowledge and membership, yes.
Exactly. So I'm not sure why it's a problem with a veteran, such as Ms. Murray, and I don't know your rank, Ms. Murray, my apologies, a veteran to get care for a specialized condition at a place because it happens to be out of network. That's the type of stuff we hear from private insurers, and both of them have problems. So if their veteran is not able to get the care at the closest VA to them, and there is the care that they need recommended to them by a provider, they should be able to get that care, and I don't give a hoot if it's on the East Coast or the West Coast, because the VA already sends people to other VISNs 2 or 3 VISNs away, hundreds of miles away, and months away. And when we consider the cost of care within the community, not private care, let me reemphasize this once again, but care within the community. And let me also say, I'm a provider of care. I gave community care. I don't think I had to have training for PTSD as an ophthalmologist to do cataract surgery. But Ms. Saindon, is it well known that men in age 40, if they have blood in their stool, that that's considered cancer unless otherwise you're a doctor, nurse practitioner?
To clarify, I'm a DNP, Doctor of Nurse in Practice.
Yes.
Not a prescriber or provider.
Okay, then I won't ask you that question. Let me just say it is common knowledge. It is common knowledge, we're trained in medical school, that if a male has blood in their stool, especially under age 40, which I think Master Sergeant Dooley was, if my math is correct from your testimony, that it's cancer unless proven otherwise. So how is it quality of care for the VA not to order a colonoscopy from a VA provider? That's not quality care. And let me say that quality care is if no care is provided, that's not quality, whether it's at the VA or community care. Do you think the cost would have been lower, Master Sergeant Dooley, if when you told your physician what your symptoms were, and I'm implying what you were, I'm presuming as a physician, if you relayed your symptoms, they would have ordered a colonoscopy, and then they would have allowed you to go for care and had your appropriate treatment? Do you think maybe the cost would have been less if it was a stage 1 cancer or a stage 2 rather than a stage 3?
I'd like the chance to live, so I wouldn't have cared what the cost was. But to answer your question, yes, I do believe treating stage 1 would have been a lot more cost-effective and efficient than treating stage 3 and for the rest of my life.
As a provider and someone who knows the healthcare system, I'm going to wholeheartedly agree with you. That's why we do screening. That's why we do colonoscopies and recommend them over age 50. And why, if someone presented with the symptoms you had, even as an ophthalmologist at the VA, I would refer you for an urgent colonoscopy. My point is this. Our obligation is to make sure veterans have access to care. If you don't have access to care in a close-by VA and your symptoms warrant, then you should get care within the community. That's our responsibility as an organization. And as a committee and as members of Congress, you shouldn't have to come to see your member of Congress to get the care you have earned. You've earned the care. So we're going to make sure that we hold the VA accountable and the community accountable for getting you the proper care in a timely fashion that you so richly deserve. Thank you, and I yield back.
Representative King-Hine, you are recognized for 5 minutes.
Thank you, Chairman Bose, and Hafaday to all of you. Thank you for being here today. Thank you for your service to Ms. Locklear. My deepest condolences. Your story is too common to so many families and parents across America. I come from the Northern Mariana Islands. It's about 8,000 miles away from Washington, D.C. That is my district. It's a chain of islands that, have a lot of people signing up for the military. We have a lot of veterans, and our issue basically is just access to service. We have one local physician contracted part-time by the VA to treat veterans 2 days a week. Referrals to available specialists in the district can be made out without prior authorization from VA office in Honolulu, which is thousands of miles away. VHA also occasionally sends specialty care doctors, to include neurologists and podiatrists, about 3 times a year. We do have emergency care, although very limited, even to non-veterans. Point is, access to these services is an issue in the Marianas, and I have always assumed that that issue was limited to our islands. And one of the reasons why I ran for Congress was to be able to improve the quality of service. But as I'm sitting here and I look at all of you and I'm hearing about all these different challenges, I'm crushed. Because if we're here on the mainland and we are not able to provide the quality of care here in America, then how are we going to be able to address the challenges of our remote islands? I don't have any questions. I just wanted to say thank you. And you deserve better. And I truly believe in my heart that through Chairman Bose's leadership in this committee, that everybody has your best interest at heart, and I'm certainly here to fight not just for my community, but for you as well. Thank you so much. I yield my time, Mr. Chairman.
And we're glad we have Mr. Harris with us today. And Mr. Harris, you're recognized for 5 minutes.
Well, thank you, Mr. Chairman, for the invitation to be a part of your committee today and for the consent to allow me to share. Ms. Locklear, first of all, I want to thank you for having the bravery to come in today and to share your son's Logan's story. It's truly an honor to have the privilege of representing a selfless American such as yourself. Your willingness to come and share your testimony, I really pray, is going to help us ensure that what happened to you and to Logan will not happen to future veterans and to their families. Your son had to wait 5 months between his initial contact for a mental health care appointment and the scheduled appointment date. Now, the law says that a wait time should be no longer than 20 days before referral to the community care program. I guess I want to ask you, are you aware of any efforts the VA has made to improve wait times or improve awareness among veterans of the community care program eligibility?
Yes, I think so.
Well, sadly, looking at the VA wait time list last night at the Fayetteville VA Medical Center, there is currently a 60-day wait time for new patients to get access to individual mental health care. You see, I'm concerned about what you went through. And I just want you to have an opportunity to really help us understand how this experience has affected you mentally and what this has led to in your own life.
I'd worked for the VA for 12 years. I believed in the VA system. I loved the veterans. So to have my own veteran that I saw in front of me 4 years suffering through what he was suffering through, I was trying to help him, couldn't get him to go. When I finally got him to go, this happened. The week he died, I thought he was actually better. That Wednesday before he died, I thought he was doing better. And then that Friday when we found him, I was just crushed. So when I went back to my facility, of course, my department knew what had happened. They had rallied around me. They had taken care of me. They had provided for me. But I knew I had the knowledge of a suicide that it needed to be reported. So when I went in to report it, They appeared to be very receptive, wanted to know what had happened. They wanted to know how, like I'd known for 12 years, well, how do we fix this? How did he fall through the cracks? But then when I told him that he was my son, everything I felt like stopped. I kept waiting for someone to call me and say, how can we talk to you? How can we fix this? What happened? All the while I was trying to work and still trying to figure out, I didn't understand what was going on. I knew my child was gone. I didn't know I didn't know they had given him a 5-month appointment. I didn't know that. I didn't know that till March of the next year. I kept asking, I just kept waiting. Finally, I just called the director of the facility myself, and I asked her about it, and she said I wasn't aware of that. But from the very beginning, I just felt like it became a cover-up. Nobody would speak to me. I kept asking, when I made her aware of it, she said she'd get back to me. She never did. As the months continued, my work performance continued to fail. I worked in the pharmacy department. I had a lot of responsibility in my job in regards to handling medications, handling drugs. I spent a lot of time the first year after Logan died. I was not at work. I could not function. I could not think. By half the year, I had exhausted every opportunity, everything that I could use to help me to continue to work my job and stay where I was at, till I finally decided I realized I couldn't work there. Every time I came through the back doors, I felt like the VA did not help my child, and therefore in my head, I felt like the VA had caused my child's death. And it made me feel like I contributed because I was part of the VA. So in my head, I had to get away from the VA. I said, I've got to get away from this place. So I have been diagnosed with PTSD, anxiety, depression, and all I asked was when my child died, I went in and I just said, can you help me? Can you explain to me, just explain to me what happened to him? And no one, they acted like they didn't see me. So now I feel like I'm disabled. I still don't function well.
Well, let me say this. You said something a moment ago that the whole attitude had been, oftentimes you heard it. How did he fall through the cracks? How did they fall through the cracks? How did they fall through the cracks? I hope that you sharing your testimony today is going to help assure that that doesn't happen again. And that, Mr. Chairman, I yield back my time.
I now recognize Dr. Nectar for 5 minutes. Welcome to Congress.
Thank you so much, Mr. Chair. I
I
apologize.
just want to let you know this is every day.
I am feeling indoctrinated, so thank you. Very much appreciate the testimony from all of the guests here, and particularly as a physician, as a mother. I want to acknowledge the challenges that our system faces. And having been a VA physician within the system, as well as a physician in the private sector who has taken care of patients from the Veterans Administration system, we have a lot of challenges ahead of us. And what Mr. Dooley went through, I've had my own patients go through. And that delay in care and the lack of continuity of care from the outside is a frustration as a physician, but it is also a failure of the system. We know that building a more comprehensive system that is accessible to the veterans is better care. Our veterans want to be seen within the VA administration. They want to have the physicians who know them, who understand the challenges of having been a veteran. We provide better quality of care, more comprehensive care, and more timely care in an integrated system when it is appropriately resourced. And I believe that that is the challenge that we need to rise up to. We need to have access for mental health, for addiction, for cancer services. And the answer is not going to the private sector. It is building the VA administration services so that we can build capacity within the system. I also speak as somebody who was a leader in a capitated system that provides coordinated care. And when we were struggling financially, we made margin. We made a successful business by bringing services to within our system to stop paying the bills outside that we have no control over, to stop the escalating costs that will continue. We understand that we are effectively supporting private practices outside of the VA administration. So respectfully, Mr. Chair, and to our community members here who have so bravely and candidly spoken for veterans, I will fight for this system, and I believe it is enforcing our need to serve veterans from within and to make sure that we resource it appropriately. And with that, I yield back. Thank you, Mr. Chair.
Thank you. As the ranking member, or does Dr. Conaway want to have a closing?
Thank you, Mr. Chairman, for holding this oversight hearing. We understand that there is a lot more information we need to collect as a committee in order to ensure that we as a nation are doing right by our veterans and making sure that they get the care that they richly deserve. Thank you to the witnesses for taking your time today and enlightening us with your personal experiences. In particular, thank you to Ms. Locklear for your bravery today. It's not easy to come and to talk about tragedy and to be as forthcoming as you have been. We are grateful for that, and we are sorry for your loss. We look forward to working with you in a bipartisan way. This committee has a bipartisan history. May it always be so. We do better when we work together. We do things that are lasting and more sustainable. So we look forward to our future work, to bring attention to those things which need fixing, and to work to make sure that that our government does the job it needs to do by our veterans. Thank you all.
And I want to thank the witnesses for joining us here today. It's clear that the previous administration had problem implementing the community care program. The community care program and the Mission Act are law. They're not suggestion, they're law. And there's a reason for that. And let me clarify this. No Republican, and I guarantee you no Republican on this committee has ever said we want to privatize, ever. Democrats have accused us of wanting to privatize. We do not want to privatize, but we do understand that the VA was not created for the bureaucrats at the VA. The VA was created for the veterans. And if we have people around this nation and veterans around the world that need services, the Mission Act should be able to do that. Now, unfortunately, I think that sometimes the bureaucrats in the VA, for the fear of privatization, refuse to do the job which we have assigned to them, and that's what things have shown up. And that's the problems, that's some of the problems we have. There's a lot of problems we have trying to get the services to the veteran at the time when they need it and as quickly and efficiently as we can. There is waste in the VA. There is. We need to make sure that it's the most unwasteful, best medical provider that it can be. Now remember, there's a whole lot more than the medical side of VA. All those other things that we deal with in this second largest bureaucracy in the world that this committee is over. We are going to work to try to correct those. This is one issue. And when I'm going to say this, this is not the last hearing we're having on this. And others will be brought before us that are those people who are the providers and the connection between the patient and the community care provider in which they and how they contract and how they communicate. And it is a communication problem both between the VA and the community care. As Representative Van Orden said, we care about the veteran. We've got to figure out how to get that there and not put people in this condition again. I want to say thank you so much for being here. I want to thank the members for a long meeting. But with that, we are looking forward to continuing to work on this. And with that point, I want to ask unanimous consent that all members shall have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objection, so ordered. This hearing is now adjourned.